Good afternoon everyone. Today I am going to talk on the preoperative optimization of severe LV dysfunction. As we all know, as a cardiac anesthetist, we have to encounter the severe LV dysfunction frequently during coronary artery bypass surgery, valvular surgery or aortic surgery, or maybe the combined surgery. So the preoperative optimization of this severe LV dysfunction patient is very important to reduce the morbidity and mortality associated with perioperative period. How these patients present to us in preoperative period? So these patients are present without the symptoms of heart failure, or they may be with the symptoms of heart failure or with the cardiogenic shock, or sometimes they are present for the emergency condition like unstable angina or crash patient. So these patients presented for, as I talk, like a CABG, valvular surgery, aortic surgery or combined surgery with severe LV dysfunction. These severe LV dysfunctions, when go for a surgery, it carries very high post-operative morbidity and mortality risks of 8 to 10%, and very high chances of low cardiac output syndrome and vital organ dysfunction in perioperative period. If they are developing the low cardiac output syndrome or AKI, that increase the twofold risk for the mortality. There are some factors which or characteristic that increase the morbidity and mortality in patients undergoing surgery with severe LV dysfunction. These are the old age, female gender, unstable angina, symptomatic heart failure, left main coronary artery disease, or coronary artery disease with involvement of any valve, multiple valve involvement, past history of cerebrovascular stroke, or renal liver dysfunction, or these patients coming for the emergency surgery or reoperations. This is the trial which was carried out long back, is a patch trial which shows the risk stratification for the coronary artery bypass surgery in patient with severe left ventricular dysfunction. They concluded that the symptomatic heart failure and reoperations are predictor of increased operative mortality in patient with the preoperative ventricular dysfunction. And conversely, if patients without the heart failure symptoms, if they undergo the CABG with relatively very low mortality despite low ejection fraction, and their length of hospital stay is prolonged significantly by the advanced age, history of stroke, and the presence and severity of heart failure. These patients, when come for the surgery or posted for surgery, we have to check for their viability assessment to predict the post-operative outcome. For these, there are various methods, mostly the non-invasive methods we are routinely using. They are the echocardiography method with the dobutamine stress test, or single photon emission CT scan with stress thallium, or PET scan where you can use a combination of perfusion PET scan with the FDG PET scan, and contrast enhanced MRI. This all you can go any one of these and find out how the myocardium is viable, specifically when you are encountering with the akinetic wall or dyskinetic myocardial wall. There are the predictor of LV functions improvement. When you are planning for the preoperative assessment, assessment and preoperative management for patient with the severe LV dysfunction, these are the factors which predict the outcome of the patient in post-operative period. They are the heart rate, arterial blood pressure, urine output, consciousness and well-oriented patient in preoperative period, warm peripheries, patient should have no acidosis, lactate should be less than 4, and improvement in alter, if patient has already alter RFT, LFT, that should improve with the treatment. ECG should be normal with the normal sinus rhythm and rate. Echocardiography also helpful to assess the functions and other parameters. Can go for a transthoracic or transesophageal echocardiography. Cardiac output study with the cardiac index, stroke volume, SVRI, PVRI, and left ventricular end diastolic pressures. And lastly, the mixed venous oxygen saturation, that is also the very good predictor for the LV function improvement. So this we have to see the serially with starting of the preoperative assessment, and after starting the treatment we have to serially see this all parameter and how these parameters are improving to assess the improvement in the LV function and low cardiac output. So our goal during this preoperative optimization is to control the heart rate, to make it the normal heart rate, keep the arterial blood pressure more than 60 millimeter of mercury, maintain the saturation above the 90%, CVP less than 10, and pulmonary artery occlusive pressure maintain around 8 to 12 millimeter of mercury. Try to maintain the cardiac output more than 2.2 liter per minute per meter square, and also stabilize the ECG in the form of normal sinus rhythm and improvement in the STT changes if it is there in previously, and maintain the urine output of 0.5 ml per kg per minute, and also correct the any metabolic abnormalities associated with, and target the lactate below 4. That is our goal for preoperative optimization. So how we can achieve this goal? This is some drug therapy or supplementary therapy is there, or mechanical supports are there to improve the preoperative to maintain the preoperative optimization in severe LV dysfunction patient. They are the preoperative cardiac drugs, supplementary therapy, ionotropes in the form of dopamine, dobutamine, as well as ionodilator like milrinone and levosimendan, or mechanical support in the form of IABP, ECMO and LVADs, temporary LVADs. These ECMO and temporary LVADs are not in our routine practice of CABG and valvular surgery, but they are helpful in when you are dealing with the patient of severe heart failure patients with the bad hemodynamics, and bridging them to for the destination therapy of either destination LVAD or heart transplant. So which medications are helpful in the preoperative optimization? When we have a patient with the heart failure and symptomatic heart failure, then these diuretics, AC inhibitor or ARB are very helpful drugs to improve the symptoms of heart failure. Can also add the beta blocker if patient have a high risk with the heart rate of more than 60 beats per minute. The beta blocker is very good to add for this optimization, and also consider the digitalis or vasodilator like nitroglycerin SNP if blood pressure is more than 100. And other cardiac drug which have shown very good role and very good effect in preoperative optimization of severe LV dysfunction patients are the statin, as emerging data suggests that the complex effect of statin that improves the outcome of severe LV dysfunction patient. It has a lipid stabilizing effect as well as anti-inflammatory properties. Also the anti-anginal nicorandil, that data suggests that improves the LV functions, and also the antiarrhythmic if patient have any risk of arrhythmia or already arrhythmia is there in preoperative period, then consider for the antiarrhythmic drug. Supplementary therapy, this is very important part of the preoperative optimization, as this carries the oxygen therapy. If patient's hemodynamics are not good, that affects the oxygen carrying capacity of the patient. So start with the oxygen therapy by the either oxygen mask or the nasal cannula. And if patient is not tolerating and not maintaining oxygenation with that, consider for the ventilation in the form of non-invasive ventilation by the CPAP or BiPAP, or invasive ventilatory support by intubating the patients. Also same time maintain the patient's input and urine output chart. Also nutritional support, that is very important part in preoperative optimization. If patient is diabetic, maintain the tight glycemic control. If patient is on the oral hypoglycemic drug, better shift to the insulin infusion. And any infective foci is there in preoperative period, start with the broad spectrum antibiotic and also go for a culture sensitivity and change the antibiotic according to the sensitivity. Nebulization and physiotherapy, that is also the important part in the preoperative period. And if with all this, if not improving the patient, one should consider for the pulmonary artery catheter for cardiac output study. Ionotropes, as with hemodynamic instability, we all initially start with the ionotropes with commonly dopamine, dobutamine or noradrenaline, adrenaline, but that helps in improving the ventricular function, but that is carries the potential risk for increased myocardial oxygen consumption. So that results in the cardiac ischemia with subsequent damage to the hibernating but viable myocardium, and also aggravates the arrhythmia. So be very careful while using the ionotropes in preoperative period to optimization, but if it is needed to maintain the perfusion pressure, one should consider after correcting the volume status as well as assessing the other factors. Preoperative ionotropes has recently been found to be associated with increased mortality and major postoperative morbidity. So very careful while using the ionotrope in preoperative period. So preoperative period, ionodilators like melrenon and levosimendan, they have a very good role. Nowadays the emerging is the preoperative levosimendan, as it has an ionodilatory effect by the positive ionotropy with the neutral effects on the oxygen consumption. This is a very important function of the levosimendan. It not increase the oxygen consumption or myocardial oxygen requirement. That is the advantage for such sick patients. It has also cardioprotective actions like myocardial preconditioning, anti-stunning and anti-ischemic effect. It has a two mechanism. One is a calcium sensitizer and one is the potassium channel activator. By calcium sensitization of cardiac muscle, it optimizes the cardiac output with less oxygen demand. This is an important thing. And also with the opening potassium channels in the cardiac mitochondria, it minimizes the risk of ischemia and reperfusion. And opening the potassium channels in vascular smooth muscle, it helps in reducing the preload as well as afterload and improving the cardiac, reducing the cardiac workload. So preoperative levosimendan, there are a lot of study has done that shows decrease the incidence of low cardiac output syndrome, decrease the complicated weaning from CPB, lower requirement for other ionotropes and vasopressors when used the preoperatively levosimendan, lower use of an intra-aortic balloon pump, reduce the ventilation time, post-operative ICU time and hospital stay time, and also reduce the mortality. IABP. When patient is not improving with your routine drugs, supplementary therapy and ionotropes, ionodilators, specifically with the coronary artery bypass coronary artery disease patients, one should consider for the IABP insertion, as it improves the diastolic coronary blood flow, it enhances the endomyocardial perfusion and increase the myocardial contractility, and same time reduce the left ventricular afterload by reducing the SVR. So it improves the ischemia as well as LV function. So this IABP has a very good effect on the preoperative period with the coronary artery disease patients, and that improves the outcome. So one study done by Lavana et al., in that study it has shown the effect of preoperative IABP insertion in cardiac surgical patient. He studied 7,440 patients over 6 periods, in whom 217 patients has a preoperative IABP, 184 patients has an intraoperative IABP and 42 patients has postoperative IABP. And he observed that in-hospital mortality was significantly lower in the preoperative group, 10% as compared with the intraoperative group, which has 16%, and postoperative group which has 29%. So risk adjusted mortality was lower in the preoperative group. So this study shows if you go with preoperative IABP insertion with severe LV dysfunction, patient with the poor hemodynamics, that will help for the perioperative period as well as improving the postoperative mortality. One other study which is a randomized control trial in which they use the preoperative intra-aortic balloon pump in coronary patient with all poor left ventricular dysfunction patients for CABG. So this study demonstrated that in patient undergoing non-emergent coronary operation with a stable hemodynamic profile and a low left ventricular ejection fraction less than 35%, the preoperative insertion of IABP does not result in better outcome. So this study shows there is no need for IABP in severe LV dysfunction patient with the stable hemodynamic preoperatively. If all these parameters are there done and patient is not improving with all of these treatment, one should consider to go for a pulmonary artery catheter insertion for assessing the all heart parameters like the cardiac output, cardiac index, and SVR, PVR, or mixed venous oxygen. As a recent study shows, the routine use of pulmonary artery catheter does not improve the perioperative morbidity and mortality, but still this has a role in some refractory cases where it is not responding to the routine conventional treatment. It is useful when clinical and laboratory assessment alone are insufficient in diagnosing and managing such cases. It helps in also titrating the dose of inotrope as well as managing the IABP. So, summarizing this preoperative optimization, when you have a patient of heart failure or with symptoms or severe hemodynamic instability with low ejection fraction, one should start with the oxygen therapy in the form of oxygen mask or NIV, and start with the loop diuretics with or without vasodilator, and see for the evaluation. If with this pressures are improving and staying above the systolic blood pressure staying above the 100 mm of mercury, then continue that vasodilator, and one should consider to add the levosimendan. If this pressures is remaining between 90 to 100 millimeter of mercury, then with the vasodilator one should consider to add the inotropes in the form of dobutamine or milrinone, like that, or also levosimendan. And if still the pressures is remaining below 90 millimeter of mercury, consider to improve the preload with the fluids, or giving the fluids, or also adding the inotropes like dopamine, dobutamine, or adrenaline. And with this, if it's showing good response, continue the same treatment and stabilize the patient and initiate the use of diuretics, ACE inhibitor or beta blocker. And with this treatment, if poor response is there, one should consider to add the vasopressor along with this inotropes in the form of adrenaline, noradrenaline, also the mechanical support in the form of IABP, and also consider to insert the pulmonary artery catheter. So, I am completing this my talk and just showing the 3 cases how the preoperative, in which cases which type of preoperative assessment optimization is required. In case 1, it's a 58-year male patient with NYHA grade 2 dyspnea who is hypertensive and smoker and presented with us for CAD, coronary artery disease with triple vessel disease, posted for coronary artery bypass graft. Patient on assessment is having normal hemodynamics and urine output. ECG is suggestive of old inferior wall MI, and echo suggestive of regional wall motion abnormality of inferior wall and anteroseptal wall with left ventricular ejection fraction of 30 to 35% with mild MR and grade 1 diastolic dysfunction. As this patient having a stable hemodynamics, no symptoms of heart failure, this patient may not require any type of preoperative optimization and can directly go for a planned coronary artery bypass graft surgery. Here the second case where it is 62-year female patient with NYHA grade 3 dyspnea. It is a diabetes type 2 on insulin with the HbA1c of 10.5. Patient is hypertensive, presented with the coronary artery disease with triple vessel disease and severe ischemic MR. This patient is posted for coronary artery bypass graft with mitral valve repair. So, on assessment we found the heart rate of 102 per minute, blood pressure of 96/54, saturation of 95% with the oxygen mask, urine output of 800 to 1000 ml per day, and creatinine is 1.9. ECG suggestive of old anterior wall MI, and echo suggestive of regional wall motion abnormality of anterior, anterolateral and inferior wall with severe MR and ejection fraction of 25 to 30%. This patient is in the ICU with the 5 microgram per kg per minute of dobutamine infusion. So, this patient is having a coronary artery disease with severe LV dysfunction with poor hemodynamics and is on oxygen in the ICU with the inotrope. So, one should consider, if it is not improving with this treatment, one should consider for the IABP insertion for more preoperative optimization or levosimendan, and then if patient improves, then plan for the planned CABG with mitral valve repair. Here the third case where 45-year-old female with the NYHA grade 3 dyspnea who is a known case of rheumatic heart disease, has undergone BMV for mitral stenosis 10 years back. At present, presented to the hospital with the unstable hemodynamics and put on the ventilator with inotropic support of 10 microgram per kg per minute of dobutamine and 0.1 microgram per kg per minute of noradrenaline. On assessment, heart rate is 122 per minute with the atrial fibrillation, and blood pressure is 86/50, urine output of 500 ml in last 24 hours with ABG suggestive of pH of 7.25 with lactate of 8. Echo suggestive of rheumatic heart disease with severe MS and mitral valve area of 0.6 centimeter square, moderate AR and severe moderate MR, severe AR with ejection fraction of 30 to 35% with dilated LA and clot, and moderate TR with creatinine of 2.1 and bilirubin of 3, and liver enzymes are normal. As this patient is critically ill and presented with the cardiogenic shock and very unstable hemodynamics, so this patient having severe MS, so one should consider for the primary stabilization with this dobutamine and noradrenaline, and if it is not improving, one should consider for the surgery with the very high risk and post-operative requirement for the ECMO with the dialysis also. Or you can also consider preoperative ECMO and dialysis, and if one stabilize, you can plan for the surgery. So both the way it is possible for this. So I am concluding my talk. To the high severe LV dysfunction patient, when presented for the surgery, it carries very high morbidity and mortality. Preoperative assessment and optimization that improves the patient's outcome. Preoperative high dose inotropes worsen the prognosis of the patient. Preoperative IABP reduce the requirement of inotropes and better outcome. Preoperative use of pulmonary artery catheter for cardiac output assessment helpful in some refractory cases, and levosimendan has promising role in preoperative optimization of severe LV dysfunction. Thank you.